Good afternoon. A little talk about cardiac output. Um, Another way of looking at this is perfusion. We have to have the right amount of cardiac output to have perfusion throughout the body. And we kind of define perfusion as the movement of oxygen or nutrients throughout the body that our cells can then use. And then after they're done using them, we have waste products, which are accumulated in the perfusion or in the blood and move back to the organ that's going to remove them. This all happens in the circulatory system, and for the circulatory system to work, we need three components. We need a pump, which is the heart, we need the fluid, which is our blood, and we need the pipes that they run through, or a container, and those are our blood vessels. Let's talk about the heart first. Cardiac output, so how much blood is being pumped out of the heart, usually every minute is how we measure it. So cardiac output is heart rate, how many beats per minute, multiplied by stroke volume, which is how much blood is in each contraction of the left ventricle. And we can even measure this as an example. We don't typically measure this on the ambulance, but there are ways to do this, more of an in-hospital type thing, but the concept is important for us to understand, even if we never really measure the numbers. So a patient's heartbeat is 80 beats per minute, and their stroke volume is the typical 70 milliliters per beat. We can simply multiply these together, 80 multiplied by 70, and you end up with 5,600 milliliters of blood being pumped through the body every minute, and that's pretty typical. Now, how does heart rate get controlled? There's a few things, or a couple of things. Here in the aortic arch and in your carotid bodies, carotid arteries, you have baroreceptors or pressure receptors, and they're really just stretch receptors. So when your blood pressure goes up, these areas get stretched a little bit, and these receptors sense that. When your blood pressure goes down, they relax, and they can then sense that. So if your blood pressure is going up and they're being stretched, there's a signal that will come up to your brain, and then your brain will interpret that, and a couple of things will happen. In this case, with the blood pressure going up, it will then send a signal down the vagus nerve to the SA node, and acetylcholine will be released, which will slow down the SA node. If the SA node slows down, heart rate slows down, and then hopefully cardiac output slows down and blood pressure goes down. Now, if the opposite is happening, your blood pressure is going down or is down too far, signal goes up, brain interprets it, and it will send a signal off of the spinal cord down to your SA node, AV node, and Purkinje fibers, or the ventricles, and this will release norepinephrine. And norepinephrine will cause your SA node to beat faster. It will cause your AV junction to speed up, and it'll cause your ventricles to beat a little bit stronger. So stroke volume is a factor of preload, contractility, and afterload, and let's talk about each of these. Preload is just the amount of blood that is returning to the heart. So all that collects in your arms and head come into the superior vena cava. Everything from the legs and body typically comes up to the inferior vena cava, and all this comes back to the right atrium and right ventricle. It goes to the lungs, and then comes back to the left atrium and down to the left ventricle. So all that returning is what we call our venous return. If we begin to lose fluid, either from bleeding out or nausea, vomiting, diarrhea, then our preload can be reduced. We can also open up the venous side of things using a medication like nitroglycerin, which will reduce the amount of blood returning to the right side of the heart also. Now, if we reduce the amount of blood coming to it, the ventricles won't stretch as much. And at least all skeletal muscles and your cardiac muscle, the further we stretch something, the stronger it's going to be. And we oftentimes relate this to stretching a rubber band. If I'm going to stretch it a long ways, it's going to have a lot of power, and I can really pop my friend with it. If I stretch it just a little bit, it's not going to sting him that much and won't be quite as funny. So we call this the Frank-Starling mechanism. Afterload is the resistance in which the heart must overcome to start moving the blood. So weight, the weight of the blood, the resistance or the friction inside the blood vessels, kind of add all that stuff up and we come up with afterload. Some of that has to do with how constricted the blood vessels are. So blood pressure, which is something we can measure. We have a blood pressure cuff, and stethoscope that we can do that, or a non-invasive blood pressure machine. So we have a number here, and it's really a factor of cardiac output and peripheral vascular resistance. The peripheral vascular resistance is again the afterload, or related to the afterload, and it's the resistance that the heart must overcome to start moving the blood. And we know that if we constrict the blood vessels, constrict the arteries and arterioles, then we're going to have more pressure to overcome it, and that's going to therefore equate to a higher blood pressure. Our catecholamines like epinephrine and norepinephrine with those alpha properties can cause some vasoconstriction, and that would then, or at least peripheral vasoconstriction, and that then increases blood pressure. And we measure this both central and peripheral baroreceptors. All right, let's talk about the blood or the fluid for just a moment. This is a little bit thicker than water, so we say it's a little more viscous. And if we were to get a tube of it and spin it down, that's kind of what it would look like. We'd have an area of plasma. We'd have a small area of leukocytes, or white blood cells, and then we'd have an area of red blood cells, or erythrocytes. And the percentage of each of these is called the hematocrit. And typically we have, I'm going to say low 40% is, 40, 41% of our blood is red blood cells. The rest of it is plasma with just a little bit of white blood cells in there. And now let's talk about blood vessels. There's really not a lot here that you shouldn't already know. We know that we have the aorta is our biggest artery, and that then splits into different arteries going to different organs of the body. Arteries split into arterioles. Arterioles then branch into capillaries. Capillaries combine together to form venules. Venules then combine together to form veins. Veins all come together to form the vena cava, and then we go back to the heart, go through the right side of the heart and the lungs, and go back out to the aorta. There's a lot of stretch in our arteries and arterioles. In fact, they can stretch at max to about 5 times what their normal is. So there's a lot of capacity left in that side of the system. We don't have quite as much stretching and dilation and constriction on the venous side, but the arterial side we can, or the artery side, we can have a lot of stretching and constriction in there. So when we're trying to regulate blood pressure, a lot of times our body will constrict the peripheral arterioles and arteries to shunt the blood to the more important central organs. Hope this helps. If you have any questions, please feel free to ask. Oops, one more thing. Forgot about the what happens down at the capillary level, and this is actually kind of important for us to understand. At the beginning of our capillaries, we have a precapillary sphincter, and at the end, we have a postcapillary sphincter. And typically, what will happen is blood will come into a capillary network, or into a capillary bed, and then these sphincters will close off. And we'll just close those off for a second so no more blood's going into that area. During this time, or this pause, oxygen, glucose, nutrients leave the cells of the vascular system and go into the surrounding tissue, and then the cells use up the oxygen, use up the glucose, and give off waste products, and then those are collected in the capillaries again. When we have enough carbon dioxide build up, we usually have acidosis at that point, and that signals then that we need to open up the pre and post capillary sphincters, and blood will now rush out, and fresh blood can rush in. And that's how it works at the microcirculation level. Now I'm sure I'm done, and I hope this helps.